Hello, ladies. What if I told you there's a blood test that predicts heart attacks even when cholesterol looks normal? That test is called CRP. But here's the problem. Some people are now saying it is more important than LDL or ApoB, and that's where things start to go wrong. So, what is CRP? CRP stands for C-reactive protein. It's a protein made by the liver in response to inflammation. So, anytime your body is inflamed, when you have infection, obesity, poor sleep, autoimmune diseases, your CRP goes up. And that's why we use a more sensitive version called high sensitivity CRP or hs-CRP, because it can detect low grade vascular inflammation. And that's where it becomes relevant to cardiovascular disease. So is CRP an independent risk factor? Yes, and that part is important. Multiple large studies have shown that high sensitivity CRP independently predicts cardiovascular events even after adjusting for cholesterol and other risk factors, meaning two people with the same cholesterol, the one with the higher CRP has a higher risk. So inflammation matters. This is not controversial anymore. Now, let's talk about some key studies. First, the Jupiter trial. It was a landmark trial. They took patients who had normal LDL and elevated CRP, and they gave them a statin. The result, 44% reduction in cardiovascular events, even though LDL wasn't elevated to begin with. And importantly, lower CRP levels after treatment were associated with better outcomes. So inflammation clearly plays a role. Number two, women's health study. This is where the confusion often comes from. This study showed that CRP predicted cardiovascular events better than LDL alone. And more recently, long-term follow-up confirmed CRP, LDL, Lp(a) are all independent risk factors. Together, they give a more accurate picture. Now, that last point is important. Is CRP more predictive than LDL or ApoB? This is where people oversimplify the data. First, LDL is not the best to compare. It is a weak marker compared to Apolipoprotein B. So when studies show CRP outperforming LDL, they are often comparing it to an imperfect measurement in the first place. Second, ApoB is different. ApoB represents the number of atherogenic particles, and across multiple studies, ApoB is a stronger predictor of cardiovascular risk than LDL. So the real comparison should be CRP versus ApoB, not CRP versus LDL. Third, they measure different biology. ApoB causes plaque, CRP reflects inflammation within the plaque. So asking which one is better is the wrong question. They are not competing, they are complementary. What does CRP actually tell you? CRP tells you, is there inflammation in the vascular system? Is plaque active or unstable? Is the environment more likely to trigger a rupture? So CRP is more about plaque behavior, not plaque formation itself. Is CRP causal? No. This is a very important distinction. CRP is a marker of inflammation. It is not the root cause of atherosclerosis. The root cause is still ApoB containing lipoproteins entering the arterial wall. Now, inflammation accelerates the process, but without ApoB particles, you do not develop atherosclerosis. So CRP does not replace lipid biology. What about statins and CRP? So one of the most interesting things about statins is they don't just lower LDL, they also lower CRP independently of LDL. And outcomes are best when both LDL and CRP are reduced. In the Jupiter trial, patients who achieved low LDL and low CRP had the lowest event rate. So this reinforces the idea you need to treat both lipids and inflammation. So how do we lower CRP? And this is where CRP becomes clinically useful because unlike Lp(a), CRP is modifiable. Lifestyle, biggest impact. Weight loss, especially the visceral fat. Exercise, sleep optimization, reducing ultra-processed foods, limiting alcohol. Metabolically, we want to improve insulin resistance. Medications, statins lower CRP, GLP-1 agonists lower inflammation. Some anti-inflammatory therapies like in the CANTOS trial. So CRP becomes a treatment response marker. Important caveat, estradiol and CRP. This is a nuance most people completely miss. Oral estradiol can increase CRP levels, but this happens because it stimulates CRP production in the liver. It's the first pass effect, not because it increases vascular inflammation. So, elevated CRP in someone who is taking oral estradiol does not necessarily mean higher cardiovascular risk. This is a lab artifact of hepatic metabolism, not true inflammation. How do we use CRP in real practice? And this is how I use it clinically. ApoB tells me how much plaque risk there is. Lp(a) tells me genetic acceleration of risk. CRP tells me how active or inflamed the system is. When all three are elevated, we have the highest risk patient. And when you lower all three, that's where outcomes improve the most. Final takeaway from this video, CRP is important. It predicts risk, it reflects inflammation, but it is not more important than Apolipoprotein B. It is not a replacement for lipid management, okay, ladies? Atherosclerosis is not just cholesterol, and it's not just inflammation. It is both. You ignore one and you miss the disease. I'm Dr. Monica Relvis, helping you understand what to measure, when to intervene, and why prevention is no longer optional. Thank you.